slide. And so although we have said like IBD debate, but I wanted to welcome both Uma and Fernando to the stage and then have it. Thank you.
Thank you so much. Turn it on. Okay. Yep. Thank you, Bilal, for that introduction. And we're very happy to be here in beautiful Monterey and NCSCG, which we have a long-standing connection to. Thank you to the organizers. So as Bilal said, we're going to start with some polite discussion. And we welcome, this is a small group, so raise your hand at any point if there's a point of clarification. And we did incorporate a lot of data that just came out at DDW.
So what we have is, we have three. Says on. Did it again? Testing. So what we did is that we have three kind of case vignettes, and it's a little bit of kind of free form in that there's a lot of kind of questions or kind of branch points that we can kind of bring depending on kind of how the conversation goes. If you have questions, and as Uma said, we try to incorporate really some key findings from DDW as we kind of discuss these. All right, so our cases are kind of IBD dysplasia and kind of a, you know, when to start, when do you kind of escalate to a biologic, as well as a case of severe ulcerative colitis that's medically refractory, as well as a medically refractory Crohn's disease. All right, so for this patient, Uma, so 30-year-old male with ulcerative colitis for 3 years and a family history of colorectal cancer. Father at age 35, so pretty early onset colon cancer, presents for a new patient visit, has been on mesalamine 2.4 grams a day with inadequate control of disease. You can see there are 5 to 7 bowel movements a day, blood urgency cramps. You can see the labs there, slightly low hemoglobin, albumin's a little bit low, CRP is definitely up, calprotectin is up. The colonoscopy shows Mayo 2 colitis throughout the colon. And so here, I mean, the question is kind of what would you offer him? But maybe before you start, maybe talk a little bit about kind of how are you seeing this patient? And then we can maybe go into like positioning of different therapies.
Yeah, so thank you, Fernando. This is somebody we see fairly often where they limp along with mesalamine inadequately controlled, but going up and down and has either not been offered or is reluctant to take the next step. And one of the things you have to think about is we are increasing his risk of colon cancer by not controlling his disease. We're reducing his quality of life by not controlling disease. So when we think about the risk of therapy, when we discuss with the patient and share patient decision making, we also talk about the risk of disease, which we don't do enough of. A lot of the conversation is we're going to give you this medicine and these are all the bad things that can happen to you, as opposed to if we don't control your disease, you have an increased risk of hospitalization, of surgery, of colon cancer. And we can get you to a point where you forget you have inflammatory bowel disease, except when you need your medicines. So for someone like this, he's only been on mesalamine. He has a lot of options. So he definitely has very active disease based on the scope in the rectum. We'd make sure he doesn't have an infection and then discuss the options.
And I don't mean to interrupt, but 2.4 grams, just go up to 4.8 as you're kind of thinking through it. Why not just go up to 4.8 grams?
You can go up to 4.8 grams, and I certainly would in this setting, but I doubt it's going to be enough. You could do the prednisone 40 with 8-week taper with 4.8 and see, but I doubt that's going to be enough for him. If he says, I want to try that before I move on, we can certainly try that. But I'd also I'd also check his quantiferon, I check his hep serologies, and I'd walk him through the options. And we have oral and intravenous and sub-Q options. And so in terms of oral, he hasn't been on a TNF yet, so he's not a candidate for a JAK, but he could be a candidate for ozanimod. He would be a candidate for vedolizumab. He would be a candidate for TNF. He would be a candidate for ustekinumab. So there's a lot of things, and based on his preference, based on his insurance, we have several things we can discuss with him.
So right here, though, you're making an assessment. You're kind of risk stratifying him, and the fact is that even though there are many other options, like you could, like you said, give prednisone, go up on mesalamine, you don't feel obligated. You don't have to kind of go through those until you get to a biologic. You looking at that colonoscopy, that's enough to convince you to move on.
Yes.
And I would just add that, if you look at the American College of Gastroenterology guidelines and recommendations, to kind of quantify a little bit or put a category, is it mild, moderate, severe? Of course, the challenge is always it's kind of mild to moderate, moderate to severe, but they both contain moderate, right? So it's always a little bit of a challenge which way to go. Here with the hemoglobin being low, CRP being up, calprotectin, about 6 bowel movements a day, that kind of starts putting them in kind of that moderate to severe category, which is the indication for most of the biologics. So these are the current medications for ulcerative colitis that Uma had gone through. And most of you are familiar with these categories. So what I will do is just simply leave that up there to you can see the list. And it's already kind of out of date with newer therapies that will likely be coming out in the near future. The one thing I will highlight is I'm going to recommend kind of a change of how we discuss our oral medication options. Whereas typically we would call things like azathioprine 6-MP, just simply immunomodulators. We have newer oral agents such as tofacitinib, upadacitinib, ozanimod, and others. And if we look kind of use from the rheumatology literature, those are considered targeted synthetic small molecules. They're not biologics, even though often we'll use them in a position similar to biologics. Whereas things like azathioprine 6-MP and methotrexate are considered conventional synthetic small molecules. So you may be seeing that change in nomenclature, and it's consistent with what we see in rheumatology. And actually, let me just kind of step back here. I've already gave the, let me go back. All right, so here, Uma, in terms of biologics, so we see kind of gave the answer away, but how do you think about the biologics and the targeted synthetic small molecules, and why not a conventional synthetic small molecule here?
So I don't think there is no good data for azathioprine 6-MP and ulcerative colitis. And now that we have such better options with better safety profiles, there is no indication to use azar 6-MP in this person. I would consider ozanimod here. I would consider vedolizumab or ustekinumab here. I would consider infliximab here. And so those would be the therapies I think that would be most appropriate. And in a patient who certainly has an interest in safety and efficacy, who's never been on a biologic, I think vedolizumab is a good choice.
All right, so started on vedolizumab, standard dosing with standard maintenance. At his 4-month visit, calprotectin is normal. And I think these questions all kind of get to a kind of a treat to target approach. When should his next scope be? And I guess there's a couple of thoughts here. I guess both in terms of his cancer risk as well as kind of following up on this treatment. Are symptoms enough? Do you do a FlexSig or a colonoscopy, and how frequently would you scope them?
So if you just looked at 3 years of ulcerative colitis and he's feeling well, normally in a treat to target approach, I would do a flexible sigmoidoscopy at 3 or 4 months after starting therapy to confirm that he has endoscopic response or healing. In his case, he had a father with colon cancer at the age of 35. So if I see him and he's still having some symptoms, I would want to optimize his therapy or do a FlexSig and see where he is before changing. But if he's doing great, I'm going to want to do a colonoscopy to do a cancer surveillance on him.
And the IOIBD, the International Organization of IBD, came up with publication recently on the kind of STRIDE 2 guidelines and kind of commenting on treat to target. And it's really kind of a progression of, someone is starting with symptoms. You try to really create a kind of a risk stratification. And I'd love to hear in a second kind of how you kind of think about risk stratification, just given that there's no great, diagnostic. And it's really a matter of just kind of going through the progression. You first want to see symptom control. That's kind of your first term target. So it's really treatment agnostic. So whatever you start, even if we had decided to go up to 4.8 grams of mesalamine with induction of prednisone, a short-term target is you want to improve symptoms. Then you have kind of an intermediate target, which is kind of the normalization of biochemical biomarkers such as calprotectin and C-reactive protein, and then kind of slightly longer-term targets, including quality of life improvements, mucosal healing if possible, as well as the absence of disability. And if at each one of those targets you're not achieved, you kind of have to rethink what you're doing, potentially change therapies or do other investigation. Now, the challenge, of course, is really how frequently to check. So you said that for UC, you usually check about 3 to 4 months after the initiation. Do you do the same thing for Crohn's disease? It just seems to be more of a, maybe more recalcitrant.
Yeah, definitely Crohn's disease takes longer to see healing. And so the minimum amount of time that would pass before I'd look again in Crohn's disease is 6 months.
Any other comments on this? And I'll just say here, you know, for doing colonoscopy, for colon cancer screening, let's see, you know, in terms of dye spray and virtual chroma, we'll go into it a little bit. But you know, for a while we've been discussing colon cancer screening. We were talking about random biopsies for decades. Then probably in the last 5 to 7 years, we started talking about dye spray chromoendoscopy, which for those who are not familiar is basically an application of a blue dye. It's almost like a fingerprint in order to kind of enhance the findings of dysplasia in someone who has ulcerative colitis or Crohn's disease, just inflammation of the colon. And if you think about it conceptually, it's kind of like a fingerprint. I mean, you can kind of see it, but if you had a fingerprint, you could put the blue dye, it really just kind of pops out. So it just makes it a lot easier to see and just makes it more predictable in terms of visualizing it. So the initial data showed that dye spray chromoendoscopy was superior to regular white light chromoendoscopy. But and that virtual chromoendoscopy, which you can see for those who have Pentax, it's MBI. I'm sorry, for iScan and for Olympus, it's MBI. Those studies initially did not show any improvement. Now, things have changed, particularly with the more common use of kind of high definition scopes. We can kind of just see much more than we could before. And dye spray chromoendoscopy, if you look at the meta-analyses combining, looking at those that have standard definition scopes versus high definition scopes, definitely a 2+ fold increase that's statistically significant in standard definition. A little bit more, but not statistically significant with the high definition scopes. Whereas in the last several years, the virtual chromoendoscopy studies have actually shown a benefit, or at least being equivalent to dye spraying. So most of the, like American College of Gastroenterology, we recently published clinical practice updates. European guidelines are also now allow for virtual chromoendoscopy as a legitimate screening method. All right, so here colonoscopy was done 6 months after starting vedolizumab. Mayo, 0 disease, so great, complete normalization of the mucosa. 5 polyps, 4 to 10 millimeters in size were found. The largest is a sessile-serrated adenoma, the rest are hyperplastic. What do you do now? Colectomy, heightened surveillance, or other? And I'll kind of maybe chat here where, you know, like I said, we recently published a clinical practice update, so I was fortunate enough to be a co-author on. And really kind of updating from the 2010 AGA guidelines in terms of how we conceptualize IBD dysplasia and surveillance. And the concept really here is that whereas IBD screening used to be very different, even the vocabulary compared to non-IBD screening, essentially what everyone here does day to day. So we would have words such as dysplasia-associated lesion or mass, and ALMS and DALMS, and, you know, taking 30, 40 biopsies throughout the colon. With high definition scopes, the concept is that, you know, you're doing about 90% during regular colonoscopy in an IBD patient that you already do. Use those same techniques. So essentially washing the mucosa, very careful inspection, looking behind the folds. And if you kind of train your eye a little bit, what I call kind of looking for things that are different than its neighbor, if you look for these atypical dysplasia signs in a colitic colon, you can actually find and find atypical signs of dysplasia. The nomenclature has also become much more similar. So instead of using ALMS and DALMS, it's really polypoid dysplasia, and you're already using these terms, pedunculated and sessile, as well as non-polypoid. And even though kind of the subcategories are often more used by the interventional endoscopist in terms of helping to remove lesions. Even if you kind of distinguish them into polypoid and non-polypoid, that's usually good enough. Remember that a non-polypoid lesion is less than 2.5 millimeters, or about half the size of a closed biopsy forceps. And then finally, in terms of screening recommendations and guidelines, one of the things that we did here is that we extended the we created this category of 5 years, which is consistent with some of the European guidelines, which is we probably, if you think about somebody who's diagnosed with ulcerative colitis at age 20, starts screening at age 28, often it was really kind of yearly colonoscopy. I mean, that's like 40 to 50 colonoscopies in a lifetime. That's a lot, just to be kind of quote unquote up to date. But as we've gotten better in terms of disease management, seeing signs of dysplasia, we really reserve that 1 year category really for significant inflammation, so that it's kind of difficult to see and assess, and high risk conditions such as primary sclerosing cholangitis, and in this case, kind of a family history of early onset colon cancer. For 5 years, there are patients we see who have a history of ulcerative colitis or very limited disease, and you scope them and it basically looks normal and repeatedly normal. Those patients probably are okay to move to 5 years. And most everyone else is kind of in the 2 or 3 year range, with the the more you've kind of seen them, including if you've had chromoendoscopy and you feel pretty confident that you've been able to see anything, they're probably okay for 3 years. Remember that a 1 year surveillance is essentially surveillance like if they had the highest risk genetic conditions such as FAP. I mean, this is pretty frequent screening for HMPCC, and we probably are not there anymore with ulcerative colitis. I don't know if you had anything else to add in terms of your screening practice or.
No, I would agree with that. I very rarely use dye spray chromoendoscopy at this point. I'm doing primarily virtual. The people that I pick for dye spray are in this 1 year category with PSC, family history, not with pseudopolyposis because it doesn't really help, or as somebody who had invisible dysplasia. And it's very important that you have a good prep. And I really emphasize that with patients, because if they have a good prep and a good look, they can extend their interval, as opposed to if they don't.
And I would just add that, even in terms of taking random or non-targeted biopsies, there was a French study that looked at 1,000 consecutive colonoscopies. They did kind of 2 heightened dysplasia techniques. So they used dye spray chromoendoscopy plus random biopsies. And what they found was an increased yield in that random biopsy of several percent in patients who had PSC, prior history of dysplasia, or what they called a tubular colon, which I think for practical purposes is kind of that really scarred foreshortened colon. And that's where you may want to just kind of add kind of non-random biopsies, but otherwise, like I said, pick either dye spray or virtual, but really just careful inspection. That gets you 80 to 90% of the way there. And actually, before we go, any questions for this first case?
And I'll just say what we ended up doing for this real patient is we said annual colon cancer surveillance since he had polyps, father with the cancer at 35, and I will use dye spray in him, referred him to Dr. Singh for genetic counseling, and we're going to keep tight control of his IBD.
Great. And then the question here, which is good, and I apologize for not clarifying, that kind of the dye spray is either methylene blue or indigo carmine.
Any other questions on this? Okay. Oh, yeah.
Maybe naive one from a non-IBDologist, curcumin.
So there was a Japanese study that looked at curcumin as a treatment for ulcerative colitis and showed some benefit. And you have to take 4 grams if you want to meet the study dose. So I don't, patients, when they ask for other things they can do, curcumin is harmless. It's something you can put into your diet. And so it's something that they can add, but curcumin on its own is generally no. Okay. All right, let's go on to the next case, severe ulcerative colitis. So these are all real people. This is a 29-year-old woman with pan-ulcerative colitis for 3 years. She had intermittent adherence to therapy for a variety of reasons. So she responded to infliximab and lost response after multiple extended delays of her infusion. She was a primary non-responder to vedolizumab, never worked for her. She had an excellent response to tofacitinib, but self-discontinued as she wanted to attempt conception. She then had a flare within 3 months and could not recapture that response when she restarted tofacitinib. And she was a primary non-responder to ustekinumab. And you can see her labs. She has some anemia. She has a low albumin of 2.7 and a CRP of 11. And the colonoscopy looks really bad. She has Mayo 3 disease, some deep ulcers there, and 8 to 10 bloody, urgent, crampy bowel movements per day. So Fernando, this person shows up in your office. Would you admit her? Would you try to do it as an outpatient? What therapies would you do? And would you start talking about surgery?
So you can see there kind of from the history here, if we kind of look, I like to, not only think about how the patient is doing, but also kind of look at trajectory or arcs. And you can see here that the arc here is from the initiation of a biologic is really, regardless of whether delays, but it's been this kind of progression, non-responder, gets better, but then, can't recapture, non-responder to another medication. So she's not completely refractory to all therapies, but clearly the trajectory is that of kind of failing multiple biologics. The only good thing here is though that there are, depending on the target, there is an ability to respond. And so it really here it's, can we pick that target as opposed to just automatically sending to colectomy? That being said, the arc here is after failing multiple biologics and really all our FDA approved, at the time, primarily products, some newer ones that have come out. It is important to have that discussion with the surgeon. Now, I will say that the way you're describing it, it does sound like she probably does need to be in the hospital. I will say that during the COVID pandemic, we did kind of get a better sense of who could be managed as an outpatient or not. And I know you're doing a very novel study looking to see whether these patients can be potentially treated as outpatients with steroids and kind of stabilized. But what I would say is that if a patient is unable to keep PO, if they're losing significant weight, severe anemia, low albumin, I think it's not unreasonable to admit them. The challenge, of course, is that what to treat with. And I know often that the issue is, can you treat them in the hospital? Because often it's very difficult to get therapies besides typically anti-TNFs. So ozanimod is one option. It's basically, and you'll go, I think, through some of the data here, but it was just recently approved for ulcerative colitis. It's a selective sphingosine 1 receptor modulator. It basically is also approved for multiple sclerosis. We can kind of go through the data in terms of whether its efficacy here is really was demonstrated in the trials, kind of that super refractory patient. I think of it usually as a medication that's probably better as an upfront therapy. The advantage, of course, that it's oral. Upadacitinib is a JAK kinase inhibitor. It's more selective than tofacitinib. Also, we'll go through some of the data. It's very promising therapy as well. In this case, she had a response to the prior therapy, so this is something that we may try. Of course, we're not able to recapture, and we can go into kind of through whether her thrombosis risk and things like that. We can talk about some of the risk safety profile. It's not unreasonable to retry therapies, particularly if they have worked. In this case, it seems like she responded, but because of insurance issues, that's not an unreasonable option. And then combination therapy is something that's kind of very novel. And I think here you kind of mean combination with multiple biologics. And I think maybe we can talk about that at the end as kind of its own separate item here. So what I'd say here is I think that given that she's had a good response to the JAK inhibitor, but could not, and it's kind of easy to give as just kind of an oral therapy, and it's pretty rapidly active. Some of the oral agents, one of their advantages with low albumin is that they tend to have a better biochemical profile in terms of working. So I think I would probably try upadacitinib here.
She is not pregnant. She was interested in getting pregnant. Yeah, no, I would agree. And as Fernando mentioned, Sarah Lewin at UCSF, we have a study called Mosaic where we're giving people outpatient IV steroids. And this is something you can do at home. Like not everybody needs to go in the hospital. We have all these UC patients that just sit in the hospital all day waiting for their IV steroids, not getting rest because they get woken up at 3 in to get a blood pressure or whatever else. So if you just are giving them Solumedrol 40, or methylprednisolone 40, they can do that at your infusion center. And if the patient is otherwise able to eat and maintain their hydration, it's a good option. and something that you can do. And when you retry infliximab, Fernando, do you do 0.26? Do you go 10 mg per kg? What do you do in that setting?
So for retry, I heard a very interesting talk a long time ago that convinced me of the following thing, and I was never able to re-find it again. So I'm not quite sure if I was awake during that actual talk, but I think for somebody who's this ill, I may probably just kind of more rapidly induce, but normally I'll do kind of a kind of 0.48, check an antibody level. Usually if you're going to have an infusion reaction, it's after the second infusion. And so often I'll get a level at about week 2. That'll give me about a week for the level to come back. And so then we can then plan ahead. If they already have an antibody to that first infusion, then I will pick a different therapy. If not, then we will continue to retry. She's a little bit different in that she is quite ill. So I would probably use 10 milligrams per kilo and would probably do, 0.26 and check an antibody in the middle as well.
Yeah, I think it was the Leuven group who did that, the 0.48. But yeah, you certainly can consider retrying infliximab in her with an immunomodulator, either azathioprine or methotrexate, and we generally do 0.48 as well, but in her, it would be reasonable to consider a higher dose. And then I always bring in the surgeon at this point. I have her meet with the colorectal surgeon either in the hospital or in our combined med-surg clinic, and we talk about the different options. And for somebody who's interested in immediate pregnancy, a subtotal colectomy with rectal stump does have its benefits, because then you're not going into the pelvis where you may reduce the fertility because of scarring in the area of the fallopian tubes, etc. Total colectomy with endoleostomy is always an option. Most young women are not going to go for that. And then, of course, total colectomy with ileoanal J pouch. So these are the 3 surgical options. We review with them and we give them phone numbers of other patients who've had this so they can start getting educated. They shouldn't be meeting the surgeon for the first time on their way to the OR. It should really be a process of coming to understand and accept this option.
And then the meta-analysis, do you still quote that from several years ago where kind of fertility drops once you kind of get in the pelvis by like a third or?
Yes. So the AFIF meta-analysis suggested a 20 to 40% reduction in the ability to conceive. However, that was all of those were primarily in the open era. And now that we're doing more laparoscopic pouches, this looks like it's better, but we still don't have good data for that. Okay, so let's go through some of the data on the new studies, on the new drug. So ozanimod is FDA approved for moderate to severe ulcerative colitis. And in that study, they randomized patients to placebo or ozanimod 0.92 milligrams. And it did work for induction and maintenance, but this looked at symptomatic response through week 10. And you can see in the graph to your left that you see a separation from placebo as early as 2 weeks. And for TNF naive patients, you again see that separation at 2 weeks. And for TNF exposed patients, it takes a little longer and you see that separation at 4 weeks. So if you're going to use ozanimod in somebody who's exposed to a TNF before, understand that it may take a little bit longer, but will still show separation from placebo. Patients always ask, how long is it going to take before I start to feel better? And for ozanimod, it's as soon as 2 weeks. And this is looking at remission through week 10. So the first slide looked at response. This is a harder endpoint of remission. You start to see that at 5 weeks for all comers and for TNF naive, and for TNF exposed patients, you start to see that at 8 weeks. So ozanimod certainly an option. Oh, this cut off. This is etrasimod. This was a late breaker at DDW. This is another S1P1. And this looked at an induction study at 12 weeks and a maintenance study at 52 weeks. So if you look at the column on your left, which is Elevate 52, you can see that at week 12 and week 52, there was a benefit for remission compared to placebo, endoscopic improvement, symptomatic remission, and mucosal healing. Elevate 12 was the induction study and again showed benefits. So ozanimod is a selective S1P, etrasimod is a selective S1P. Ozanimod is FDA approved for moderate to severe ulcerative colitis. Etrasimod just showed data, and you may be seeing this in the clinic in a few years.
And can I ask you a question? So This basically works by, it's an oral agent. It basically works by affecting the ability, kind of internalizes the S1P receptor so that it doesn't allow the lymphocytes to kind of go to areas of inflammation. The class is associated with certain things like bradycardia initially in the trials, kind of macular edema, et cetera. Do you have any tips in terms of kind of a checklist here? So often we'll, the thought is to get maybe a baseline EKG, only if patients have macular edema or some other eye condition that you need an ophthalmologic exam, but any kind of tips for using this class of agent?
Yeah, so this agent can pretty much be used in most people. You would avoid it in someone with diabetes who has a history of macular edema or a history of bradycardia. Fortunately, if you prescribe the medication, it comes with a nurse who will do the checklist for you. And so so you don't have to worry about doing all of that. But those are the things that you would look for.
And then the only kind of interesting is that for Ozanimod, there's kind of a 1 week ramp up just where to monitor for possible bradycardia.
Correct. Okay, so this is UAchieve, which is upadacitinib, which was FDA approved in February for moderate to severe ulcerative colitis. And the way you use this is 45 milligrams once a day for the first 8 weeks, and then you can go to 15 or 30 milligrams thereafter, and you have to step down. You're not supposed to keep it on 45 after that 8 weeks. There was some data looking at an additional 8 weeks of 45 milligrams of DDW that did capture a small percentage of patients. And if they've been TNF exposed, which is every patient in the US going on upadacitinib, 30 milligrams is preferred over 15. So in the study, you can see a remission clinical response at week 2 and week 8, and you can see that there are pretty big differences, with placebo, let me go back. So you can see, so if you look at clinical response at week 8, it was 64% for upadacitinib in bio-experienced versus 13%. So quite a bit of difference. So if you are bio-exposed, you still have a good response versus if you're non-bio-exposed. And this is looking at, again, the primary and secondary endpoints for 15 milligrams and 30 milligrams, again, shows significant benefit for endoscopic improvement and remission, and HEMI is histoendomucosal improvement. So a combined score of histology and endoscopy. So the numbers for upadacitinib are quite remarkable, especially in biologic exposed patients. So this really is quite a breakthrough. And presented at DDW, it shows relief of ulcerative colitis symptoms as early as day 1. You start to see a separation from placebo, and that's certainly quite impressive and something, again, to share with your patients that within a few days, you might start to feel better, including if you've been on a biologic before. It's also effective in the treatment of extraintestinal manifestations. This was presented at DDW, showed improvement in anemia as well as arthritis, and studies have shown efficacy of upadacitinib for ankylosing spondylitis. So if you have a patient with joint pain associated with their IBD, this is a good option. So adverse events, of course, are one of the things we talk about with upadacitinib. There was 1.3% of patients had VTE in the study population at 30 milligrams. There were no MACE events in the 15 and 30. So a lot of this concern for VTE and MACE comes from the oral surveillance study, which again was rheumatoid arthritis patients over the age of 50 who had one cardiac risk factor already. And they're compared to TNF patients who received tofacitinib had higher rates of VTE and MACE. However, in the ulcerative colitis population, we have not seen that. So I don't know if any of you remember back to primary care days when you used a Caprini risk model for screening people for DVT. And so this is something we mentally do when we think of who's at risk for VTE, but this is a more formal score. And just having IBD gives you a point. And so if you have a score less than 2, you have a low risk of VTE, score of 2, moderate, and greater than 5 is the highest risk. So you can think about this when you are considering a patient for a JAK inhibitor, and kind of helps you keep this in perspective. I would say that oral contraceptives, so women on oral contraceptives are at increased risk for VTE, and oral contraceptives are not as effective as progesterone only contraception. So in general, all women are recommended to use progesterone only, which are the implants or the IUDs, and that does not have an increased risk of VTE. So if you have a woman, you want to put on a JAK inhibitor, certainly talk to her about progesterone only contraception.
How
Yes.
do you feel about hormone replacement therapy?
So,
That's the question.
so the question is hormone replacement therapy. So if you're using estrogen, that does increase your risk of VTE. And so for this drug, that would be something to think about.
And then, so just to kind of maybe before we get to this slide, so we have in terms of JAK inhibitors, tofacitinib, upadacitinib, both are oral. Both are JAK kinase inhibitor, with tofacitinib being a pan-JAK, upadacitinib being more selective. The main, even though the original study was in tofacitinib in terms of the label, the JAK inhibitors have essentially kind of assumed that thrombosis risk. And so just to kind of clarify, you might have mentioned it, but it's really kind of a second line agent. It's one of our few second line agents. It has to be used after the failure of a TNF, which is actually a little bit different even how they approach it in rheumatology. I will highlight that the oral surveillance study that was published in New England Journal earlier this year is actually a very interesting study. The question always is, does it relate to our IBD patients? And if you think about the way that the study was done, it was actually meant to generate a certain number of events. And then once that happened, the data was looked at. And it's a little bit complicated, but it's a discussion of non-inferiority. So the study themselves, some of the outcomes don't look very different, but since it didn't meet the threshold that they had pre-specified, the thrombosis risk was attributed to ustekinumab. I will to tofacitinib. I will recommend that you read the accompanying editorial, which I think is a very balanced approach, which is really that the risk is something we have to discuss with patients. But for a patient who is not at increased risk of thrombosis and may not be over 50, one cardiovascular risk factor, and to be honest, even those who might but have failed all other therapies, we shouldn't really deny this class of therapies. I think that's probably the take home. I don't know if you would agree with that. It's just mainly having that discussion and just being sure to monitor and just trying to pick the right patient.
Yeah, and I heard at DDW that 80% of people getting upadacitinib are men. So I would say do not deny women therapy based on their reproductive potential, please. So unless they are planning on getting pregnant right away, there's no reason a woman cannot get a JAK inhibitor. So if we were to go down this scenario of JAK inhibitors and ozanimod, if they have new ulcerative colitis failing 5-ASA, you cannot use a JAK because you have to have failed a TNF. So, but you can use ozanimod. Moderate to severe UC failing anti-TNF showed you data that the JAKs and ozanimods can be used here. If they have low albumin, that's where maybe a biologic won't be great because they're going to clear it quickly and where you want to think about a small molecule. Sorry, concomitant MS and UC, ozanimod can be used here. You cannot use a TNF. Peripheral arthropathy, tofacitinib and upadacitinib will have some benefit there for the joint pain, for axial spondyloarthropathy. There's data from upadacitinib showing benefit. Inpatient acute severe UC, there are some studies like Peter Higgins' group at the University of Michigan, and our group have also used inpatient JAKs for somebody who's been on an infliximab failing at high dose, again, off-label, higher dose than you would use as outpatient. But what about a history of heart disease? So if they have a history of atherosclerotic heart disease, history of cardiac risk factors, significant cardiac risk factors, then a JAK probably is not the right drug. If they have type 2 heart block or bradycardia, ozanimod's probably not the right drug. If they have a history of eye disease, uveitis or diabetes related, you would not want to use ozanimod in that situation. And both of these are oral molecules, which means they will cross the placenta in the first trimester, and you do have some concerns with pregnancy and very little human data. So I would avoid if I could in pregnancy. Okay, So what about some of the new biologics that were presented at DDW for ulcerative colitis? Mirikizumab is a P19, it's IL-23, and it did show benefit in moderate to severe ulcerative colitis in a phase 3 study. So this is something that you may see soon for ulcerative colitis. Gazolcamab is another IL-23 P19, showed efficacy in moderate to severe ulcerative colitis in the Quasar study. Of course, risankizumab is also an IL-23 P19. We'll talk more about that for Crohn's. You may be seeing that for Crohn's as early as this month. This was a combo trial where they combined, so we always talk about in IBD, the therapeutic ceiling. We only seem to get so far, and then there's a certain percentage of patients that don't respond. But what if we combined biologics? So the Vega study combined gazolcamab, IL-23, and golimumab, anti-TNF, in patients with moderate to severe ulcerative colitis. And they looked at the primary endpoint at week 12. And then the final endpoint will be week 38. And they presented the week 12 data, and it shows here that golimumab plus gazolcamab was better than golimumab alone, but not really that different from gazolcamab alone. So at least for the week 12 induction, there doesn't seem to be a significant benefit, even though there's like a 9% delta, and it is a small number of patients. And that was for response. For clinical remission, there was a benefit for the combination therapy over either alone. So the idea is, can we induce patients with combination therapy and then continue only one of them for maintenance, which is safer? So in the induction period, we give them a big hit to try to control disease and then maintain going forward. There was no real significant difference in adverse events when you looked at combination versus monotherapy through week 12. So for our patient, we gave him IV steroids to control symptoms as an outpatient. We gave her upadacitinib, which induced remission. We talked to her about the pregnancy issue. We discussed subtotal colectomy with rectal stump versus J-pouch, but she's going to defer pregnancy for now and have a solid remission and maybe revisit that in a year. So any questions on case 2? So that's a great question. Since she did not respond to tofacitinib, why would I think upadacitinib would work? So in the upadacitinib trials, none of the patients had been on tofacitinib before, so we really don't know the answer to that. However, she did initially respond to tofacitinib. She self-discontinued, and then when we restarted, we were unable to capture response. So she wasn't a primary non-responder, which is why I thought that she might have a chance with a different agent.
And I'll just bring up also that concept of kind of recycling therapies, where, you know, we've all seen where you start a therapy, it seems to work, then it stops working. There's some type of escape mechanism. And so sometimes by going back to an earlier therapy, the kind of whatever's driving that inflammation may be responsive. So usually for me, it's like if there has been in this patient, I think both infliximab and tofacitinib would have been potential options, just given that there had been real response in the past. But correct, you are, you know, looking at the data and trying to use your best guess, you know, and remember that these are cases where your options are quite limited.
Do you think that there are physiologically different subgroups, and that's why people respond to some medicines versus others? And if so, what's the progress in looking at patients at the beginning of their disease and saying, I'm going to go this way versus that way, with either clinical factors or biomarkers informing that decision?
So that is a huge area of study. And the question is it the microbiome? Is it their genetics? Is it what biomarkers they have? And there really isn't an answer that works for everyone, but that's part of this whole idea of precision medicine, is who would respond to what. In the pediatric population, it's much more clear because they can do a genetic test, and you have the very early onset IBD patients where they have a clear IL-10 deficiency or a clear IL-1 deficiency, and you can target therapy. In adult onset IBD, it's much more multifactorial than in pediatrics, so it's more challenging, but it is something that is being evaluated.
But not there yet. Yes.
To use for these patients?
So the role of cyclosporin, I mean, if you look at the clinical trial data and just kind of experience at kind of cyclosporin centers, it definitely is an option, particularly in this patient. At least for me personally, it gets to kind of ease of use, and so I will say that I think it's always an option, but I personally have not used much cyclosporin, particularly with biologics.
Yeah, so in the East Coast, they do use some cyclosporin for induction therapy, particularly Mount Sinai and University of Chicago. I think most other places do not. There were 2 randomized trials of cyclosporin versus infliximab in severe UC that showed no benefit, but they would argue that you can induce with cyclosporin in somebody who'd failed a TNF and then maintain them on something else. As Fernando said, we don't really use it that much anymore.
But it is an option, at least on paper.
Do we have 6 minutes for the next case, or
No,
6
but we're
minutes before questions?
Well, no, remember before questions.
Okay.
Correct. So, and then just last question that had been brought up, positioning of ozanimod, and this last one is much shorter. Positioning ozanimod with the other biologics.
So
The third rail of IBD.
So ozanimod compared to the bio. So I would say ozanimod, ideally I would use in someone who's TNF naive. I think that's where it has the best data. So in that person, you would use vedolizumab, ozanimod, in that range, somebody maybe who prefers an oral therapy. So someone with moderate to severe ulcerative colitis who is TNF naive is your ideal candidate. Once they've failed a TNF, they become more refractory, and that's where it may not work as well, though it did show some efficacy data from the True North study. It just takes a little bit longer.
All right.
We'll speed go through this case.
All right. So for refractory Crohn's disease, we got rid of our timer. Okay, got it.
You have about 20 more minutes.
Okay, thank you. All right, so 31-year-old patient, eczema, asthma, and severe refractory Crohn's disease, diagnosed at age 19, father with UC, brother with Crohn's. You can see there the line of prior therapies, including infliximab, ustekinumab, sofosbuvir, vedolizumab, methotrexate, adalimumab, with side effects or failure to induce remission on all of these agents. And I'll just kind of stop for a second here and just say, it is so important in taking a history, just really understanding not just simply that they failed it, but really trying to either go through notes or try to talk and why that failure, because if you do get to that refractory point, it does kind of help you kind of choose which might be the next step if there's something that's reversible, such as losing insurance. While on ustekinumab and methotrexate, had severe interface dermatitis, felt most of it from methotrexate, stopped ustekinumab due to insurance and was no longer effective after restarting it. Then started upadacitinib, had a great response, reduced to 30 milligrams, lost response. On increase was not recaptured. And you can see there, white count is elevated, hemoglobin is down, albumin is slightly low, CRP is significantly up, as is the calprotectin. And what would you do here? Kind of been on everything. So the options are combination therapy. Do you go go back to the roots, use exclusive enteral nutritional diet? Do you go kind of, most severe bone marrow transplant? Given she had this at a young age, would you do genetic testing similar to what Dr. Mahadevan, the 3-time champ, suggested in terms of precision medicine? And I know there's some updates that we're going to go through here, but your approach to kind of the refractory Crohn's patient, and is that different really from the UC patient?
It is different from the UC patient because the UC patient can have a colectomy and hopefully be done. And this patient with ileal and colonic disease, she really does not have the option of surgery. That what would you do? You can't take out everything, and you'd need something to maintain her afterwards. So here's where you really get into some of the other things you can do. And I know these are very, very rare cases, but the principles are the same. What are the other options? What are the things that she has, recycling therapy? Can you go back? Can you add something? What is a role of diet? And again, if you have someone who was diagnosed as a child or under the age of 20, getting genetic testing with an in vitae panel is really key. In her case, she had an IL-1 link. And so she's somebody we could add anacurna to, and I apologize for using the brand name. She also had a CARD14 variant linked to a psoriaform disorder. So we were going to add risankizumab, and this is where your PDGI people can really be helpful.
All right. So there were a couple of studies at DDW, and this is was presented and again got cut off a little bit, but important because looking at upadacitinib, we had talked about how it's FDA approved for ulcerative colitis, but there was really not a lot of information for Crohn's disease, and more importantly, the tofacitinib study in Crohn's was negative. So really, right now, its main indication is ulcerative colitis. There was not an FDA approved therapy for Crohn. So any use was really off-label. So this was a phase 3 double-blind placebo-controlled trial, randomized 594 patients to receive either upadacitinib or placebo for 12 weeks. There was a mandatory taper, and you can see there, similar to most studies, there was a co-primary endpoint of clinical remission and endoscopic response at week 12. And you can see there, this was a rather refractory population with over 60% of patients failing 2 or more biologics. And you can see there at week 12 that, that the upadacitinib 45 for induction was superior to placebo for remission. So quite a refractory population, 40% still compared to 14%. And obviously the maintenance data in studies like this, where you're allowed prednisone and a taper, are important. But the conclusion was that upadacitinib 45 milligrams was superior to placebo for inducing clinical remission, endoscopic response, corticosteroid-free remission, and endoscopic remission. And some of us have been using this kind of off-label for some time based on some prior therapy, but it's nice that these data are published, and it seemed hopefully moving more towards a label indication. So your thoughts on upadacitinib for Crohn's?
We have about 30 patients we've done this in, and we submitted our, we've had really great success. And in these patients, I keep them on 45, which is definitely off-label. Using it in Crohn's is off-label, but once they've failed everything, I'm not going to take the chance of dropping them to 30.
So you have to review that it is off-label, and you still discuss the same thrombosis risk
Correct.
as you would with tofacitinib.
Correct. Sorry that things got cut off there.
Yeah, we're sorry. So also at DDW, actually for an ECHO, is risankizumab. And this was another option for patients with moderate to severe Crohn's disease. So just as kind of a reminder, there is ustekinumab, which is basically a monoclonal antibody. We kind of call it an IL-12/23 inhibitor. Basically, it inhibits the P40 subunit, which kind of gets to the IL-12 and 23 pathways. The therapies we were mentioning before, mirikizumab, as well as guselkumab, and now risankizumab basically block the P19 subunit for IL-23. And although related, there might be some, it's not half as good. There might be some mechanistic differences why this actually could be a better pathway. So this was a post hoc analysis of the randomized placebo-controlled trials. You can see that the patients had moderate to severe Crohn's, inadequate response or intolerance to conventional therapies. They were randomized to different induction dosing. And the key endpoints here are the traditional ones: response, remission, and ulcer-free endoscopy, as well as deep remission. And you can see there some quite good outcomes, at least for the induction. And you can see that there's a benefit if you look at response, remission, and ulcer-free remission in both bio-failure and bio-naive patients, with some pretty good response and remission rates.
And I will add, this is FDA approved for other indications, but at much lower doses. And it's anticipated that this gets approved for Crohn's any day.
All right, actually, and this is the maintenance data at week 52, and you can see, again, both for failure and naive patients. So I think that's kind of the take home. All right, and then, yeah, these are blinding, but safety similar to other agents. All right, so this is actually quite super exciting, except I'll be at the end. There's kind of, it's half the study that we really wanted. And so this is when we talk about combination treatment. This was a triple combo of vedolizumab, adalimumab, and methotrexate, and really trying to get patients into that deep remission with the thought is if you kind of put out the fire, it's a little bit easier to kind of maintain remission. This was an open label phase 4 trial of triple combination. You can see there. And these patients were biologic naive and were recently diagnosed, so less than 24 months, moderate to severe Crohn's, and at high risk of complications. And what you can see there is that endoscopic remission at week 26, about 35%, clinical remission at week 26, endoscopic remission, clinical remission, 54%. Their conclusion was that in a biologic naive population who are at high risk of complications, produced endoscopic and clinical remission at week 26. And this was presented as an oral. I think we need more of these studies, but what's obviously missing here is the placebo group. We're trying to kind of see here, is that a good number, 54? Is that lower than we expected? So I think here it's a little bit, we have to kind of wait, but you can see here that the trend is to do these kind of combination therapies. So before moving on, Uma, I don't know if you have a thought on this study.
No, I agree. It needed a comparator, but it was interesting.
Right.
So I think, the point of this talk is not to terrorize you with all the different variations of therapy that you could do, but to understand that there are options. And for your moderate to severe patients, there are whatever the patient wants. I want something safe. I want something oral. I want something injectable. I want something IV. Right now, it's really a golden era for IBD therapies where there's really a lot of options. And even in the patient who's failed multiple therapies, there are options. So one thing that I would also encourage is that to find yourself a good IBD nutritionist, because there's a lot they can add. One thing we tell all our patients, we recommend a Mediterranean diet. We recommend avoiding emulsifiers and additives in food, eating as much freshly prepared food as possible. That is the basics, making sure your vitamin and mineral levels, including zinc, B12, vitamin D are normal. But what more can we do? What kind of therapy can we do? And our pediatric colleagues have been ahead of us on this, in part because you can force kids to eat this stuff and it's very hard to force adults to do it. But there have been multiple studies that have demonstrated benefit. And so these are a listing of studies using exclusive enteral nutrition as therapy, and at least in one pediatric cohort that did show benefit versus TNF. But something that is increasingly being used in adults is a Crohn's disease exclusion diet plus partial enteral nutrition. And so this study, which was published in Gastro, was in kids. It was a 12-week study where in group 1, they had Crohn's disease exclusion diet plus 50% of calories from formula for 6 weeks, followed by the exclusion diet with 25% formula from weeks 7 to 12. And then group 2 just received exclusive enteral nutrition. And you can see that the CD/ED group in blue did better for remission, normalizing CRP, and sustained remission. And also it was better tolerated, which is very important. So what is CD/ED? There's multiple things that are avoided, including dairy, but for the most part, they can eat fruits and vegetables, they can eat lean proteins, and it is something where they can't socialize because they have to drink formula all the time. It doesn't work like that. They can go out to dinner and they can eat, but it is something that needs to be done under the supervision of a nutritionist. There's no way I would have time to monitor and go through all of this. You do need a good nutritionist to work with, and this is phase 1, phase 2, and phase 3. And the formula we often use is modulin.
And I just wanted to highlight, besides nutrition support here, I saw Dr. Che earlier. I don't know if he's still here, but increasingly centers are starting to also have kind of that concept of food as medicine. At Kaiser, for example, we have one of our physicians. We kind of have a similar food kitchen where we're actually teaching patients how to cook and eat. We make the recommendations and our nutritionists make the recommendations, but there's still that extra layer of support, which is really how do you make that into a real action plan? And so I think that's also one of the novel things I think we'll probably see over the next couple of years, is that concept of food as medicine, and actually kind of teaching patients to cook these diets that we're increasingly learning have certain beneficial effects.
Exactly. Absolutely. And this really gives also the motivated patient some sense of control over their disease, which is very important to them. And it works. It truly does work. So for our patient who failed all these things, she normalized, her calprotectin cut in half after 6 weeks of doing the Crohn's disease exclusion diet. So there is objective evidence that it works. Louis Cohen at Mount Sinai has restarted a stem cell transplant program for refractory Crohn's. And this is just 11 patients he presented at DDW and did show some benefit. The big study was out of Europe several years ago, and they did have 1 or 2 deaths in that study. So this is truly for your most refractory patient. And the idea is that you sort of reset their immune system. And he's saying here that it's not true that it actually resets, but may reach a new equilibrium, and they may be able to respond to the therapies they responded to before. So if, so in this very refractory group, this is the next level of what can be done. So for this patient, we continued her upadacitinib 45 milligrams daily. We added risankizumab because she also had sweet syndrome at the dermatology dose of 150, started her on this Crohn's disease exclusion diet with peripheral enteral, with the enteral nutrition with our nutritionist. Now 2 to 3 bowel movements a day. Calprotectin dropped by 300 points in 6 weeks, and 755 sounds high, but it's the lowest calprotectin she's had in the last 3 years. And so definitely a great trajectory. And so remember to think outside the box. Think of all the tools that you have in your armamentarium. It's not just drugs. You also want to, we did genetic testing on her to figure out the risankizumab piece. We involved our nutritionist, and we're using off-label therapy. So this is an extreme case, but really to highlight what all the options are.
Thank you very much, everyone, for your time and attention. Any questions for the third case?
Thank you so much, Uma and Fernando.